If the nuances of eating disorders confuse you, this is the right video. First, we're going to discuss anorexia nervosa. Anorexia nervosa is very high yield, both for the psychiatry shelf as well as the STEP exam, because there's so many medical problems that can come from anorexia nervosa. For diagnostic criteria, it must meet 3 criteria. There must be restriction, a restriction of energy intake leading to significantly low body weight, which is defined as a BMI of less than 18.5. There also must be this intense fear of gaining weight or persistent behavior that interferes with weight gain, such as excessive exercise. There also must be this disturbed body image. Even if they are not overweight, they feel like they are overweight, and they have a denial of seriousness of the current low weight that they are at. Next, we're going to talk about the anorexia nervosa subtypes. And this is very important because our idea of anorexia in the general population is different from the DSM criteria for anorexia nervosa. And this is why test makers like to trip you up on these points, because it tends to make people get the questions wrong. So first, there's the restricting type. And this is the type we typically think about with anorexia. So this is where there's weight loss accomplished primarily through dieting, fasting, or excessive exercise. During the last 3 months, the individual has not engaged in recurrent episodes of binge eating or purging behavior. The primary focus is purely on decreasing calories and burning energy. Now, the binge eating purging type, this is what tends to mess people up. During the last 3 months, there is recurrent episodes of binge eating or purging behavior. Purging methods could be self-induced vomiting, misuse of laxatives, diuretics, or enemas. And you might think, isn't this bulimia? Well, the key distinction between bulimia and anorexia is bulimia, the person has a normal weight. In anorexia nervosa, the weight remains significantly low, below that 18.5. That is what you need to look for in the exam. So the physical findings and complications of anorexia nervosa is extremely high yield because there's so many of them and they can be deadly. So for endocrine, there can be amenorrhea, which is due to hypothalamic suppression, reduced sex steroid hormones, estrogen and testosterone, hypothyroidism, low T4, low T3, normal TSH, and hypercortisolemia, which is a result of stress response because they are starving. Now, cardiac and vitals, these are very important because this could indicate that the person needs to be hospitalized. Bradycardia, often less than 40, hypotension, QT prolongation, which can lead to arrhythmias, and mitral valve prolapse due to heart muscle atrophy. Now, for skin, hair, and bone, there's the fine, downy body hair, which is for warmth because they're very cold. Alopecia, so there's going to be hair loss, thinning. Osteopenia and osteoporosis, of note, this is something that is irreversible, even if they get better, and that can be a test question. And then dry skin, cold intolerance. Labs are often tested as well. So for vomiting, there can be low chloride, low potassium, alkalosis. And then if they're using laxatives, it can be metabolic acidosis because of the diarrhea. There also can be leukopenia due to bone marrow suppression. Again, all of these things are incredibly high yield. Make sure you know this slide. So how do we treat anorexia nervosa? If someone needs to be hospitalized, it's typically because their body weight is below 20 to 25% of their ideal body weight, or if they are showing medical instability, which would be bradycardia or hypotension. Psychotherapy Family therapy is recommended for teenagers, and then CBT is recommended for adults. Again, if CBT is an option, just click on it. For pharmacology, SSRIs are not effective for core symptoms. However, atypical antipsychotics such as Olanzapine can be used for weight gain because that is a side effect of these atypical antipsychotics, and we need the patient to gain weight. Now, this next thing that we're going to talk about is extremely high yield, and that is refeeding syndrome. So it is dangerous fluid electrolyte shifts when refed too quickly. So you have to be very careful when trying to get this person's weight up. Insulin surge drives electrolytes into the cells. You need to know the labs: low phosphorus, low magnesium, low potassium. Be able to recognize this as refeeding syndrome. The risk of refeeding syndrome leads to cardiac failure, arrhythmia, seizures, and rhabdo. Next, we're going to discuss bulimia nervosa, which also frequently shows up on exams. So for diagnostic criteria, the person must binge eat large amounts of food, loss of control, and then they must compensate for it. This can happen either by vomiting, using laxatives, exercise, but these are the key features: are binging and then compensation. The frequency must be at least 1 time a week for at least 3 months. Physical findings include Russell's sign, which is calluses on the knuckles from vomiting, and dental erosion, parotid enlargement. These are key findings that frequently show up on exam questions. For lab findings, there's low chloride, low potassium, and they are in metabolic alkalosis. And then for laxatives, because of diarrhea, that can be metabolic acidosis. So how do we treat bulimia nervosa? The management strategy is to use a combination of SSRIs and CBT. Fluoxetine is actually the only FDA-approved medication for bulimia nervosa, but we can use other SSRIs off-label. The fluoxetine does require higher doses than for depression, typically 60 to 80 milligrams. And then, of course, CBT is the first-line choice for therapy. If CBT shows up on your exam, just click it. You're probably going to be right. Nutritional counseling is also vital. Now, very high yield contraindication. Wellbutrin. Wellbutrin is contraindicated in bulimia nervosa. Actually, you should probably just avoid Wellbutrin in all eating disorder patients because they can have electrolyte abnormalities, which lowers the seizure threshold, and Wellbutrin lowers the seizure threshold. It's especially dangerous when there's electrolyte abnormalities with purging. So you really need to know the difference between bulimia nervosa and binge eating disorder because they can look very similar when you're reading quickly through questions. So for binge eating disorder, there's recurrent episodes of binge eating associated with marked distress. The key distinction is that there are no behaviors to compensate for this binge eating. There's no purging, there's no fasting, there's no excessive exercise, unlike in bulimia. The presentation: patients are typically obese and suffer from related comorbidities such as metabolic syndrome, cardiovascular disease, diabetes. Treatment for binge eating disorder is SSRIs. Of note, Vyvanse is actually FDA approved for binge eating disorder. Just binge eating disorder, not bulimia. Topiramate can also help with binge eating disorder. Next, we will talk about avoidant restrictive food intake disorder, which is not as common as some of the other eating disorders, but it can be confused with anorexia nervosa, so you need to know how to distinguish between them on the exam. So in avoidant restrictive food intake disorder, individuals do not meet enough caloric nutritional needs, just like an anorexia, but they do not have the body image distress seen in anorexia. They can have sensory sensitivity. This is particularly common in autism, where there's avoidance based on taste, texture, smell, appearance of food. They fear adverse consequences of eating, such as anxiety over potential negative outcomes like choking, vomiting, nausea. And they also can have just a low interest in food, apparent lack of interest in eating, very low appetite. So these are all the possibilities that might show up on the exam of why they're not eating, but it will have nothing to do with body image issues, and that's how you can distinguish them from anorexia nervosa. For more high-yield videos, click on the playlist on the right. Otherwise, that's it for today. Good luck on your exam.